We are live now. So, hello and welcome all of you on a very warm Sunday evening over here. Though KKR may be defending, RR may be chasing, but we have the best minds in the country, the medical wizards here with us to attend the round 2 of DocTutorials National Assessment, DNA as we call it. So DNA was basically was supposed to be conducted in 2 rounds. The first round of which was conducted through an in-app assessment. It was a 30 question, 30-minute round that was conducted on the last Sunday, and about 500 students have taken that test, and we have the top 10 candidates, top 10 contestants of that participating in round 2 in a live Viva round, in a live round, which will be streamed in front of you to make sure that we have the best minds of the country grabbing that prize money that there is. And with me as quizmasters today is our Dr. Rahul Rajiv, MBBS, MD, DM neurologist with us. He is one of the brightest minds of the country that I know of, definitely, because he is a doctor that I have reached out to personally, and he has treated my wife without adding medicines but by deleting medicines, and that is an experience I will never forget. And we also have Dr. Manish. Dr. Manish is also very happening on Instagram. Dr. Manish Taneja over here is an expert in emergency medical and critical care. He is also on board with DocTutorials for the emergency medical and critical care part in the super specialty segment. And I'm very happy to have both of you over here to host this particular quiz as the quiz masters. All the questions that are going to be in the 3 rounds of this quiz have been created and curated by these two super minds along with Dr. Vishal Gabale. Unfortunately, Dr. Vishal is not able to attend this sessions today, though he has contributed to the question pool of it. He is not able to attend the session today because of some personal issues. But yes, we have the Dr. Rahul and Dr. Manish. Good evening, Dr. Rahul. Good evening, Dr. Manish.
Hello,
Good
Mr.
evening.
Ravi. How are you?
Good
Good evening.
So, I don't know why, I'm also feeling a bit nervous for the quiz. I know that I'm not a participant, but again, I do not know why, because I was very fond of quizzing during my residency days as well. So,
Same here, sir. Same here.
yeah, it's a great initiative by DocTutorials, because after the success of the NEET tests and INI-CET coaching programs that we have introduced the medicine PG residency program with a slightly different touch of helping residents across India to have a sort of good patient-based approach while dealing with scenarios rather than the entrance point of view alone. And this is running successfully with across India. A lot of MD and DNB residents are using the residency program of DocTutorials. I'm happy to know that. And I'm also very excited. I know that Ravi has already introduced, but Manish is again one awesome person, I should say, because he's so dynamic. And you can just follow him as well in Instagram, Resuscitate India. As you travel in a bus or you travel in a car, not while driving, but otherwise, you can just have a look at his reels to learn a lot from him. I'm sure that many of you are already following him as well. Wonderful educator and a wonderful human being as well. So on my behalf as well, welcome Dr. Manish to this program.
Thank you so much, sir. Thank you so much for this amazing introduction, which I don't know it's how much of it is true. I mean, I'm just learning from your lead. I mean, you are the lead, and I'm just following in the footsteps, trying to be a better educator, I hope. And the video should come out soon on DocTutorials.
And also to all the viewers and the participants, I extend my regards from Dr. Vishal as well, who unfortunately could not join the program, but he's a strong pillar of our team as well. So again, to all the participants and viewers, a big hello from Dr. Vishal as well. So I think, the participants, we need to know more about them. And I think, Ravi, let's, let us know, because it's totally unbiased. I don't know the participants. I'm just seeing them for the first time. Neither does Manish, and so we don't have a personal deal of sharing the cash prizes. The cash prizes looks a bit attractive, okay, but still, we'll try to be unbiased.
Can
So, Ravi,
we make the deal now?
yeah, the deal can be made now. So, Ravi, we would like to know who are the participants and from
Yeah.
which colleges they are from.
So,
Because he has not even told me who are the finalists, which college. I told him 2 days back, just share the list, but he did not. Okay,
so
right.
we have 7 out of the top 10 participants who have joined us right now. We are hoping that the others will also catch up with us. I hope you know they are not in caught up in some medical emergency somewhere. But otherwise, we hope that the others will catch up as well with us. So to introduce each of you, I would like all of you to speak on behalf of yourself. For example, I am Ravi Teja. I am a postgraduate, but not in medicine. I'm not a doctor, but I work as a product manager and I live in Hyderabad. If you could tell that much about yourself, each of you, we would love to know where you work. We would love to know where you are pursuing your PG, or if you have completed your PG, which college or which place you belong to, so that we get to know you even better.
One more line about Mr. Ravi. He's the tech wizard behind all that we do. I mean, he supports us immensely in everything. I mean, even today, it wouldn't have been possible without him.
Absolutely right. Absolutely right.
So that is the statement we should say for the last. Fair enough, sir. So let's start with Dr. Kavit Shastri.
Yeah, good evening, everybody. It is really a privilege to be here. I have done my MBBS and MD from BJ Medical College, Ahmedabad, and I'm an aspiring cardiologist.
Right.
That's it.
Great.
Welcome,
all
Dr.
the best,
Kavit.
Kavit. All the best. All the best.
Good luck.
Thank you.
Dr. Kuldeep Soni.
Good evening, everyone. Myself, Dr. Kuldeep, and I have completed my MBBS from AIIMS Jodhpur and Medicine MD from AIIMS New Delhi. I have just completed my MD a few months back only.
All right. All the best.
Welcome, Dr. Kuldeep. Good luck.
Dr. Jaskaran Singh.
Good evening, everyone. I'm Dr. Jaskaran Singh. I'm a second-year medicine resident at Dayanand Medical College, Ludhiana, and I aspire to become a neurologist one day.
Great.
Welcome, Dr. Jaskaran. Good luck.
Good luck.
Dr. Gopal Krishnan.
Good evening. I am Gopala Krishnan. I am done UG from Madras Medical College. Now studied PG final year from Viluppuram Medical College.
Okay. Right.
Good luck, Dr. Gopal Krishnan.
Thank you.
Dr. Mohit Chaudhary.
Good evening, everyone. Myself, Dr. Mohit. I have done my PG from Dr. Ramanodoy Hospital, New Delhi, and I aspire to be a gastroenterologist.
Great. So welcome.
Good luck, Dr. Mohit.
All the best.
Dr. Anand T.
Sir, I'm currently pursuing my final year MD from Government Medical College, Alappuzha, Kerala. I'm basically from Kollam, Kerala.
Okay.
Hello, welcome and good luck.
And all the best. All the best.
Dr. Harpal Singh.
Good evening, everyone. I am from RKDF Medical College, Bhopal, Madhya Pradesh.
Hello.
Right.
Third year.
Welcome and all the best, Harpal. So I think we've got a good representation from Pan India, students across the country. They're battling out. I think South, North, we have got candidates from everywhere.
All four parts, it seems like.
Yeah.
West,
Great.
South, probably East is, I think, missing.
Right. So Ravi, I think we have done with the introduction part, and now I think this is time where the candidates would like to know more about the rules of the quiz. So Ravi, if you can just tell them on how the quiz will unfold, and I can see some, some chat as well. Jaskaran, I think you've already got some fan following. Somebody's already wishing you the best, and I request other candidates also to just call all your friends, just to support you in the chat box, not with answers, but again with good lucks. Okay. So Ravi, just tell us about the rules of the quiz.
Yeah. So the quiz, the entire quiz is divided into 3 rapid rounds. Rapid round 1 and rapid round 2 will be conducted on this platform called Kahoot, where we will be sharing internally within the group that we have with the participants, I will be sharing the QR code of the quiz. You have to log in into that. The round 1 will have 45 seconds for every question, and it is 15 questions, MCQ based questions, 45 seconds for every question. The top 5 people among the 7 participating will move forward to round 2. So round 1, unfortunately, is an eliminator. Round 2 too is an eliminator. Round 2 as well will be on Kahoot. It is a different game and it is in a similar format. However, it is a round based on 15 case-based questions. 15 case-based questions which have been created by our experts over here, which will, for each of the questions, you will have 1 minute to answer, and that will also be conducted on Kahoot. The good part about conducting the quiz on Kahoot is that all of you get equal chance. All of you get the same chance to attempt the same question at the same point in time. And you will be awarded not only on the basis of your accuracy, but also on the basis of the speed at which you are answering. And you will be able to see the leaderboard of where you stand among the participants after each and every question. And after the entire round, we will be choosing the top 5 who will be graduating to the next round. After second round, we will be choosing the top 3 who will be graduating to the third round. And third round is where we will simulate what happens in a Viva during your PG, right? And that round will be taken by Dr. Rahul Raju, where he will be conducting a case scenario based Viva. And he will be judging you on the basis of not only your acumen, but also your approach, how you approach the problem, how you construct or articulate the answer, as well as how accurate you are in terms of the diagnosis or the line of treatment. And that when we approach round 3, Dr. Rahul will be able to explain it much better. So without further ado, I am going to share
one point to add
yeah,
to all the candidates, just to ensure that we have a fair quiz. During the entire quiz, the video and audio should be turned on. So otherwise, you will be automatically disqualified. Okay, this is just to ensure that it's a fair game. During the quiz, the video and audio should be turned on. Okay, so because we know that all of you are mature adults, just to maintain the transparency. That's it. Okay. So round 1 will be, I think, it's like a warm-up round. The questions are relatively on the easier side, and as we move on to round 2, we'll go 1 notch higher, and then we'll have round 3. So I think Ravi will take you through round 1, and Dr. Manish, anything you have to tell the candidates just before the quiz starts?
Okay, keep yourself centered. I mean, it's just a game at the end of the day. I mean, you have read everything. I'm pretty sure we have tried to keep it as clinical as possible. And good luck to all of you.
So the candidates wish you good luck. And I'll tell you that, having qualified to this round amidst all the participants itself is a victory. I really appreciate each one of you because it's not easy having competed with the best brains across the country. So you're all winners, but again, it's just a matter of filtration. And we totally know that this will depend on luck, multiple other factors. But yeah, that's how a game unfolds. Yeah. So over to you, Ravi.
So the QR for round 1 has been shared on the group. I request all of you to join the round 1 quiz. And it will give you an option to choose a nickname. Please don't choose a random nickname that we will not be able to identify. Choose a nickname which corresponds with your name. In fact, go ahead with your original name itself.
I think it would make sense if you could use your phones. I think it has been shared already.
Dr. Kavit has joined. Once all the 7 participants join, we will be starting the quiz, and I shall be sharing the screen as well, so that the other participants, other people who are watching it live, can also see what the questions are. Dr. Jaskaran has joined, Dr. Kuldeep as well.
And to all the viewers, just to keep yourself tuned to the entire duration of quiz. I'm sure that you will also learn something new. So watch out for the quiz because you're going to learn a lot of new points as well, as you go through rounds.
Dr. Mohit is in.
I request all of you to, stay tuned to the full length of the quiz.
And new clinical scenarios and probably new knowledge as well. And it'll be fun. The ledger board is really fun.
Yeah.
Also, once you have joined, please try not to refresh your browser.
Dr. Harpal has to join. So all the doctors, while I will be displaying the question on the screen over here, you please look at your own screens and try to answer the question there itself because you get marks for scoring it faster as well.
Devi, there is a query by Dr. Kuldeep. Can you just address that?
That's fine, Dr. Kuldeep.
Okay.
That's fine, Kuldeep. That's fine, Doctor. I think, has everyone joined?
So 6 of the participants have joined. Dr. Harpal Singh has to join. Yet.
Dr. Harpal's video is also.
Harpal, can you please turn on your video?
Yes, sir.
So I think all of them are joined.
Dr. Harpal has not yet joined the Kahoot.
So I already joined.
Kahoot. Have you joined the Kahoot QR code? Ravi, can you just...
Yeah, now we have Dr. Harpal as well. Yeah. So
as I said to all of you, the first round is relatively an easier round. We want to make you comfortable. The second round will be the one based on scenarios. Okay.
So here we have all the 7 participants who have joined and we are going live with the quiz. Brace yourselves.
Ten seconds remaining. Question about systemic lupus erythematosus. Not a part of the immunological domain. Yes. Yes. Answer is option A. Answer is option A. This was a part of the SLIC criteria, but not a part of the immunological domain in the 2019 ACR-EULAR criteria. Right. So I think 4 of them have answered it correctly. Right? Right, Ravi? Yes. So Anand is leading. You can see for the viewers, this is the scoreboard. Ravi, can you just educate, the viewers about how this, marking system is? You need to score more or you need to score less. How does it, work?
Obviously, we need to score more, sir. It is not a ranking system. This is the marking system. So the marking system is based on 1, your accuracy, 2, the speed of answering. So if you answer it correctly, you get points. But if you answer it faster, like the fastest finger first on KBC, you get more points. So right? So even all the 4 of them who have answered it correctly, even if 4 of them have answered it correctly, you can see that 4 of them have different marks that they have secured for this particular question.
Right. That
Based
was
upon the time that they have taken.
Yeah. That takes us to the next question.
Yes, next question, 45 seconds.
Which of these is a limitation of interferon gamma release assay for immune diagnosis of latent tuberculosis?
You have to be quick. You have to be accurate.
2 people have already answered. 3. Okay. I think they have gotten the hang of it.
25 seconds left. Under 10 seconds now.
Okay. So,
Dr. Rahul, you're muted.
okay.
Right. So the answer is option
No.
B. Okay, false positive results due to infection with Mycobacterium cancerci. Okay, so that will be the answer. And let's see the scores.
I think nobody answered it correctly, so the score still stands, the previous score.
Right. Let's go to the next question. Relatively simple one.
A patient admitted in the ICU following head injury has developed hyponatremia. What is the likely diagnosis? Serum osmolarity 272, urine sodium is 45. Urine output is normal and patient looks to be clinically evaluable. I think 5 people have already answered. Yes.
Yes.
The correct answer is 𝐒𝐸𝐷H.
How many people have answered it correctly?
4 of them.
Okay, 4 of them. 4 of them have gone for option A. Right. So can we have the scores now? Any changes? Here
Yes,
comes
sir.
Kuldeep.
Dr.
Kuldeep is now leading, followed by Dr. Gopalakrishnan, Anand, third position, Jaskaran, and Kavit Shastri. Right. All right. So can we have the next question on screen, please?
It's only been 3 questions. There are 12 more questions to go in this round. Everyone has an equal chance to make it to the playoffs.
Yes.
I think SRH is also not eliminated now.
Yeah. So come on, everyone. Come on.
Which of these is not a feature of amiodarone-induced thyrotoxicosis type 1?
This topic is important even for NEET SS comparison of amiodarone-induced thyrotoxicosis type 1 and 2. It's a previous NEET SS question as well. Option A usually has an underlying thyroid abnormality. Option B usually occurs 3 years of starting amiodarone. Option C, high vascularity in color flow Doppler. And option D, treated with antithyroid drugs. So yes, 4 of them have answered correctly. Yes, right. So let's have the scores now. Dr. Gopalakrishnan, Kuldeep, Jaskaran, Kavit. Come on, all of you. Expect all of you to have a tight competition. Okay, right. Come on, everyone. So can we have the next question now?
Which of the following is false about rheumatoid arthritis associated ILD? A, more common in females. B, tobacco exposure increases risk. C, clinically evident disease occurs in 10% of the cases. And D, both A and B.
So let's see who's able to answer this.
20 seconds to go.
Rheumatoid arthritis associated interstitial lung disease. I think all of them have answered. Yes, Ravi?
6.
6 of them have
2
answered.
people have answered correctly.
Okay. So basically, rheumatoid arthritis, we all know, is more common among females, but the rheumatoid arthritis associated interstitial lung disease is more common among males. So the answer is option A. How many of you got it right? 2 of. Right.
So there is a shuffle in the scoreboard and the leaderboard. So Dr. Kuldeep Soni is again at the top, and followed by Dr. Kavit Shastri, close margin.
Yeah.
And the third is Dr. Gopal
good
Krishnan.
answers from the in the chat box as well. Asif, Karthik, Dr. Miraj. Okay, good. Right. So I think we'll go to the next question. Question number 6. Come on. Which of the following is true in case of pseudo hypoparathyroidism? "25 seconds left. Relatively easy question. Five people have answered. Right. So I can see that 6 of you have got this question right. Okay. Yes. Answer is option A. Let's go to the next question, please. So here, Kuldeep Soni leading, followed by Kavit, Gopal Krishnan, Jaskaran, Anand. Come on. And I can see that Kavit has answered 3 correctly in a row. Great. What about this question? Which of the following condition artificially raises the value of HbA1c? Iron deficiency anemia, sickle cell disease, chronic liver disease, and acute blood loss anemia. Quick. 3 of you have
5
answered.
seconds to go.
3 of you have answered. "11 seconds, 10 seconds, 9 seconds. Yes. So 3 of you have answered correctly. Iron deficiency anemia is the correct answer. And let's see the scores right now. Do we have a change? Kuldeep is still leading, followed by Kavit, Gopal Krishnan, Jaskaran, and Mohit. Yes. Right. Let's go to the next question. Which of the following treatments would be likely to produce clinical benefit for this patient? Okay, so what is the patient having? Let's have a look at the clinical presentation. Read it carefully. Two of you have answered. 25 seconds. For the viewers, we have kept 45 seconds for this round. The next round, we'll give 1 minute.
1 minute.
Yeah, this round will be 45 seconds, and we have got the timer under 10 seconds now. Yes, absolutely right. And I'm sure in the audience, they've also guessed it right. It's 3,4-diaminopyridine, and we know that the clinical diagnosis here is that of Lambert-Eaton myasthenic syndrome. Right. So I think we have got Kavit leading, followed by Kuldeep, Jaskaran, Mohit, and Gopal Krishnan. Great. Right. So let's go to the next question. Question number 9. We have just passed halfway. Others, you can still catch up. Factual question coming up. Factual question coming up. You can still catch up. Come on. Quick. You can get some serious points.
I have already answered.
Yeah. 5 of you have answered. Okay, right. Right. So yes, so
I think 6 are playing.
Yeah. So yes, linagliptin is absolutely right. 5 of you have answered it correctly. 1 of you couldn't. Don't worry. We've got still another, I think, 5 6 questions left. Kavit is still leading, followed by Kuldeep, Mohit, Gopal Krishnan, and Anand again comes to the table, I think. He just went down. Now he's coming up. Come on, Anand. We've got around 6 questions left. Let's go to the next question. Question number 10 on your screen. Question for pulmonology. False statement regarding cryptogenic organizing pneumonia. Age group, 2nd to 3rd decade. Restrictive pattern on pulmonary function testing. Imaging shows subpleural consolidative opacities. Good response to steroids. 3 of you have answered. 3 of you have answered. "12 seconds. 5 of you have answered. Timer under 10 seconds now. Yes. Yeah, correct. Because the age group is on the higher side. It's not 2nd to 3rd decade, which is false. It's usually in the 6th decade or so. So, yeah, I think only one person has answered it correctly. Right. Ravi, can we know who that person is who has answered this question correctly? Should be Kuldeep, right? Because he's come up.
Kuldeep.
Kuldeep, great.
First,
Great, great. All right, all right. Let's go to the next question. Okay. Which drug is not used in? Okay. So there is a used missing there. Which of the following agents is not used in the acute therapy of aortic dissection? Not used in.
All of you have already answered. 22 seconds to go.
So it's about being
It's
quick
an easy one.
and being accurate. Being quick and being accurate. Right. So hydrolysine, yes. I think only one of you have answered it right. Okay. Right. So answer is option D. And yes.
Dr. Kuldeep.
Yeah. Let's go to the next question. Simple one on Bartter syndrome. Simple one. Very simple one on Bartter syndrome. True statement. Okay. True statement. I think you should answer this in 10 seconds.
Yeah, they have.
Yeah, yeah. Right. So correct answer is option D, hypercalciuria. Let me just have a look at the scores. Okay. We have gone to the next question. All of you, we have gone to the next question, please. Yes. The following are features of cryptic miliary tuberculosis except cryptic miliary TB. Some really good participation in the chat box as well. Karthik, Chahat, Praveen Kumar, good answering. Amrita is also answering well. See, only one of you have answered. Remember, cryptic miliary TB, how is it different from the normal tuberculosis, miliary tuberculosis? They're seen in elderly and they'll have normal chest X-ray. Okay. So normal chest.
If it was having miliary appearance, then it wouldn't be called cryptic.
Correct. So that's it. Yes. So Kavit again comes. Right. So let's go to the penultimate question of this round. Again, a simple one. Come on, everyone. Identify the stage of pericarditis. From the ECG, 4 stages. Which stage do you think this ECG belongs to? 4 of you have answered. 4 of you have answered. Yes, it's stage 3. 3 of you have answered this right. 1 of you have answered it's stage 2. 2 of you have answered it is stage 4. Answer is option stage 3. It's option C. Right. So before I go to the next question, the final question, can I have the scores? Can I have scores? Yes. So let's see the last question of the first round. This round will decide which 5 candidates will go to round 2. Right? Let's have the final question of round 1 on screen. choose the correct option. Okay, the question will be displayed right now. Which of the following features would be the most compelling evidence that a patient with a peripheral polyneuropathy has an acquired demyelinating neuropathy rather than hereditary demyelinating neuropathy? So on a nerve conduction study, how does a neurologist get a clue that this one is acquired and not a hereditary demyelinating one? Okay. 4 of you have answered. I've asked this question once in one of the NEET SS mocks of DocTutorials. So if you are writing those, you will answer this correctly. 3 of you have answered it rightly. It's patchy conduction, because patchy slowing is occurring in acquired, whereas in case of hereditary one, it will be a uniform demyelination. Okay. So answer is...
So while talking about the question, while dictating the question, you, I think, gave a very important clue that you said on nerve conduction. I think it only made sense.
Oh, okay. Right. My mistake. Yeah. Right. Okay. Anyway, it's about picking the mistake from the examiner as well. Somebody is smart enough to identify. Okay. Right. Good. So can I have the final scores of round 1 right now? Anand is at the 3rd position, Kuldeep at 2nd position, and at 1st position will be... Okay. So well done, but this is just round 1. And here we'll have 5 participants getting selected to round 2. Okay. So Ravi, everything good? Do we have those 5 candidates? Can I have their names also, please?
So we have Dr. Gopal Krishnan and Dr. Mohit also qualifying for position 4 and position.
Okay, Gopal and Mohit. So 5 of them will battle it out for the round 2, right?
Yeah.
Right. Okay, fine. Let's start round 2. Meanwhile, I'll just get my questions ready for round 3 as well. Okay, let's get started. Okay.
I'll take over. Okay. So
yeah. Go ahead, sir.
So we will continue with the round 2. I think we can drop the other participants. I don't know how will it work.
So we have Dr. Kabit, Dr. Kuldeep, Dr. Mohit, Dr. Anand, and Dr. Gopal Krishnan, who have qualified for the round 2. Dr. Jaskaran, you have played it with great heart and you have given your best in this. But unfortunately, as per the rules, as round 1 was an elimination round, you don't qualify for round 2. However, we do have something to offer from our side to you. If you're not already a subscriber, we offer you a 3-month subscription unlocked for you for medicine residency, because you are currently pursuing your residency, and that comes along with NEET SS as well. So please go to the app and make sure that you are utilizing the content to the best of it. Thank you so much for participating, Dr. Jaskaran.
Thank you for participating, Dr. Jaskaran, and well played. It doesn't really matter. Like we already said, like Rahul sir already said, that you already are a winner amongst, the top minds of the country. So it doesn't matter. Good luck for your future, and do utilize the offer that you have been given.
Thank you. Thank you very much. And all the best to everyone for the quiz.
Yeah. That's the spirit.
So as we speak, I am going to share the QR for round 2 in the same group. So did any of you participants over here experience Kahoot before? Do you think it's a good way to conduct a quiz?
Yes.
Yes, sir.
Was it fun? I think the thing is with the virtual sessions, you need to ensure that nobody is utilizing any means to copy and cheat. So Kahoot becomes the good platform because it's time based and you cannot really use uh, other means.
So I have shared the QR in the group. I request all of you to join. Dr. Anand has joined, Dr. Kavit, Dr. Gopal Krishnan has joined, Dr. Mohit. We also have Dr. Kuldeep. We are good to go, sir. I am.
Good luck to everybody.
Yes.
So starting the round two, DNA rapid rounds, round two. So the first question, what is the first line of treatment? 50-year-old male, history of CLD, admitted to ICU with fever and abdominal pain, diagnosed with spontaneous bacterial peritonitis, has ascites with pedal edema. The lab values are below. What should you do for thromboprophylaxis? What should be your treatment of choice for thromboprophylaxis? Heparin, 5,000 unit twice a day, mechanical thromboprophylaxis, and avoid pharmacological. Enoxaparin, 0.6 mg per kg, or after correcting INR and FFP and with platelet transfusion, you should start thromboprophylaxis. What is the choice? 4 of you have already answered. 10 seconds ago, all of you have answered. So yes, the answer is to start enoxaparin because IFCH guidelines, they recommend starting enoxaparin even till the creatinine clearance is more than 30 with adjusted dose. The correct answer is enoxaparin 0.6 milligram per kg. So seeing the leaderboard, only one of you had answered. So congratulations, Dr. Anand. Moving on to the next question. So what does this X-ray show? It's fairly simple. Pneumomediastinum, hydropneumothorax, pneumopericardium, hydropneumopericardium. What does this X-ray show? "45 seconds to go. This round has more time. We are giving 1 minute in this round. And the top 3 participants will move on to the final round, which will be a Viva-based round taken by Dr. 𝐒𝐥𝐢𝐧𝐚𝐥𝐸 sir. So all 4 of you, 5 of you have answered and 4 of you are correct. Yes, this is hydropneumopericardium. You can see the air fluid level in the pericardial cavity instead of the chest. So Dr. Mohit is leading, Dr. Kavit Shastri close second, Dr. Kuldeep is close third. It's a tough competition even with Dr. Anand and Dr. Gopal Krishnan. Remember, the top 3 will move on to the next round. So fastest fingers, ensuring accuracy. Which is the least likely drug to be causing this ABG disturbance? So 30-year-old female with drug overdose, and ABG was pH of 7.24, PCO 24, bicarb 12, CO2 90, lactate 2.1, sodium 135, and chloride 90. Which drug do you think is the least likely causing this toxicity? 4 of you have already answered. 30 seconds to go. Yes, topiramate, because topiramate, so the ABG in question, it had high anion gap metabolic acidosis. So because of high anion gap metabolic acidosis, topiramate becomes the answer because topiramate causes not high anion gap, but a normal anion gap. So Dr. Kavit is leading. Dr. Anand is close second. Dr. Mohit is third. Dr. Kuldeep and Dr. Gopal Krishnan, don't worry, you can still catch up. So come on. Moving on to the next question. They're fairly simple clinical questions. What does this image show? So you can see the image is of the monitor of a 68-year-old male who presented with chest pain with inferior wall myocardial infarction post PTCA. And monitor is showing this. You can see with the arrow, there are two arrows, a big arrow and a small arrow. You can see on the arterial line trace, what does it show? Two of you have answered, 30 seconds to go. Three of you have answered. Yes, four of you have answered correctly. Pulses alterance, along with being a marker for pericardial effusion, it is also a marker for poor LV systolic function. It has been observed. So the correct answer is pulses alternance with poor LV systolic function. So again, Dr. Kavit is leading. Very nice. Dr. Mohit is close second, and Dr. Anand is third. Dr. Kuldeep and Dr. Gopal Krishnan, you can still do it. There are many questions remaining. There are 11 questions remaining. So come on, buck up. You can do it. Good luck. Moving on to the fifth question. What is the likely compound? 50-year-old female with shortness of breath, oliguria expressed history of taking some unknown compound a few days back. And urine changed color on diethylate sodium solution. Three of you have answered. You can see the tongue, you can see a chest CT with ground glassing and some fibrosis, and you can see blue color on the urine. What do you think is the toxin ingested? 25 seconds to go. Four of you have already answered. Paraquat. Yes. And it should not have been in view, but yeah, well, good luck. So it has the classical appearance of the paraquat tongue and the diatonic testing. The darker the bluer color of urine, the worse the prognosis because the amount ingested is more. So Dr. Kavit, Dr. Mohit, Dr. Anand, top three. Dr. Kuldeep, you are still very close, so you can do it. Dr. Gopal, come on, try hard. Moving on to the next question. So which score would you use to risk stratify rebleeding and mortality pre-endoscopically in this patient who has history of alcohol use disorder with hematemesis pre-endoscopically? Remember the word pre-endoscopically. Should be fairly simple, fairly easy. Somebody wanted to be a gastroenterologist, I guess Dr. Mohit. It's GB or a Glasgow Blatchford score because pre-endoscopically only this score can be used. Complete roll call needs endoscopic classification, but you can use pre-endoscopically roll call as well. So yeah, the correct answer is GB score. So who did? So Dr. Kavit and Dr. Anand. So Dr. Anand is second, Dr. Mohit is third, Dr. Kuldeep is fourth, and Dr. Gopal Krishnan, come on, you can still do it. 9 questions to go, 7th question. What's the next best step? 55-year-old oliguric CKD presented with traumatic brain injury, signs of impending herniation. What would you do next? 4 of you have answered. Okay. All 4 answered correctly. You give hypertonic saline because, CKD, not producing urine, mannitol can cause issues because it is renally excreted. So it has even seen to cause paradoxical raise ICP in studies. So hypertonic saline becomes the drug of choice here. And you should target, like, if you're using 3% hypertonic saline, then, the dose is 1.5 to 2.5 ml per kg. Some studies have quoted higher doses as well, 5 to 6 ml per kg also. So Dr. Kavit is again leading. Dr. Anand is second. Dr. Kuldeep is third. So moving on to the next question, 8th question. What is the next best step? 35-year-old female, lower limb fractures, both bone immobilized, 7 days, in slab, OCP, shortness of breath, SpO2 is 97, tachycardia, BP is normal. How should you evaluate pulmonary embolism in this case? "24 seconds to go. Three of you have answered. It's a straightforward thing. Even if you are calculating score in your head, it is still straightforward. Yes, directly go for CPPA. All of you have answered correctly because it's a high-risk patient. So D-dimers is of no use. So Dr. Kavit is leading. Dr. Anand is second again. Dr. Kuldeep is third. So the leaderboard is staying the same. So I encourage Dr. Mohit and Dr. Gopal Krishnan to come on, change the scoreboard, change the leaderboard. 6 questions to go. Which is the likely drug this patient has consumed? 24-year-old female with a mood disorder, multiple prescription tablets, ABG shows this: pH 7.24, PCM 20, PO2 68, BiCAP 14, lactate 1.8, sodium 134, and chloride 122. What drug would you suspect? 3 of you have answered, 40 seconds to go. "26 seconds. 4 of you have answered. Only 1 person remaining. Okay. So you saw that the ABG had negative anion gap. So lithium is the common culprit, which confuses the chloride electrode, and chloride electrode read it as chlorine instead of lithium, and it causes negative anion gap. So that ABG had negative anion gap.
I think nobody has answered that correctly, right?
Yeah.
All right.
Okay, moving on. The scoreboard stays the same. Dr. Kavit is leading. So what does this ECG suggest? You're supposed to tell me this ECG, you're supposed to read this ECG in a 64-year-old male who has CAD with permanent pacemaker, comes with chest pain, sweating since 1 hour. And you're supposed to tell me what it indicates, or which criteria would you use? Two of you have answered. 26 seconds to go. 3 of you have answered. Come on, you can see that this is a paced rhythm in a 64-year-old with chest pain and sweating. Paced rhythm, which criteria do you use? And that criteria has 3 parts to it. It's a weighted criteria. Which part does the patient with the CCG corresponds to? Yes. So 5 of you have correctly answered. Why? 6 have answered.
Any
Yes.
questions left? Dr. Manish, how many questions left?
Sir, 5 more to go.
Okay,
5 more to go.
okay. So it's
Yeah.
coming to the final 5 before the final 3 gets selected. Great.
Dr. Kavit is leading. Dr. Anand and Dr. Kuldeep next to Dr. Mohit and Dr. Gopal Krishnan. There are 5 more questions to go. You can still do
we
it. So
can
come
still
on.
have a change in the tables. Please, come on,
Yeah.
everyone.
The table can turn. What should be the management option here? So 76-year-old male with hypertension, the ECG is given, has history of ischemic cardiomyopathy, heart failure with reduced ejection fraction, comes to you after 12 months for routine examination. BP is 134/78 and 90 of heart rate. And this is the rhythm. What would be your treatment of choice here? Fairly simple clinical question. What would you do? Twenty seconds to go. 3 of you have answered. Four of you have answered and 10 seconds to go. So last 5 answers. There is another participant in the quiz. There are 6 participants in the quiz.
Okay.
So yes, correct. Because you don't know the onset of the atrial fibrillation, the ECG was of atrial fibrillation, the rhythm strip. Since you don't know the onset, you have to start with systemic anticoagulation with either a DOAC or warfarin. So Dr. Kavit is leading, Dr. Anand is next, Dr. Kuldeep is third, and again, Dr. Mohit and Dr. Gopal Krishnan, fourth and fifth. There can still be hope. So come on, third and second place. Try for it, Dr. Mohit, Dr. Gopal Krishnan. The next 3 participants, the top 3 winners will move to the third round. Which calcium salt should be avoided in this patient? CKD5, hypocalcemia, calcium and vitamin D, long-term PPI for Barrett esophagus. Which salt should be avoided? Best avoided. 2 of you have answered. 40 seconds to go. 3 of you have answered. The patient is on PPI for Barrett esophagus, has CKD, has been diagnosed with hypocalcemia, and started on vitamin D supplementation and calcium. Oral calcium, which salt should be avoided in this patient? So calcium carbonate should be avoided as it requires acidity in the stomach to get absorbed, which with PPI is best to be avoided. So 2 of you have answered it correctly. And let's see which 2 have answered correctly. Dr. Kuldeep and Dr. Kavit. Dr. Kavit is Dr. Mohit. Okay, Dr. Mohit has answered. Very nice. And Dr. Kuldeep has answered. Very nice. Dr. Mohit, there is still 3 more questions. 38-year-old female, abdomen pain, constipation. This is the chest. This is the X-ray. What is chest X-ray? What is it suggestive of?
2 of them have answered. 3.
50 seconds to go.
4.
4. It's a clinical presentation with an X-ray is shown. The patient has GI symptoms. 38-year-old female. Rest history is not available, but you can see this X-ray. What is it? Yes. 4 of you have answered correctly. It is Chilaiditi syndrome because the patient is also having symptoms. So it is a syndrome. Otherwise, it would have been Chilaiditi sign. So, you can see Hostras. It's not air under diaphragm. It's Hostras are visible.
Am I seeing a change? Am I seeing a change in the list?
Yes, sir. Dr. Mohit has come up to third place. Dr. Kuldeep, very nice.
Very
Dr.
close.
Mohit,
This is
Dr.
very
Kuldeep
close.
is very close.
I think you've got one
Close third
question.
and fourth place.
One question left.
Yeah, we have 2 questions left, sir. 14 and
This is
15.
becoming interesting. This is becoming
Yeah,
interesting.
it's going to get interesting.
Yeah. Great.
What is the likely diagnosis in this scenario? This is an ECG of an 18-year-old male who comes with history of loss of consciousness while walking, which lasted for a few seconds, and patient regained consciousness on his own. History of palpitation in the past, and you can see the ECG. What can be the diagnosis here? All 4 can look to be the cause, but what is the likely cause based upon the ECG? What can you see in the ECG? 30 seconds to go. 4 of you have answered. 5 of you have answered. You can focus on lead V1. Yes. Arrhythmogenic right ventricular dysplasia. Epsilon waves were visible in lead V1. So
For the recent INI-CET question, there was this question on arrhythmogenic right ventricular cardiomyopathy with ECG epsilon waves. It figured in the recent INI-CET exam as well. Good question.
Right. So,
okay.
There is change in scoreboard again.
Right, change is there.
It's very close for second and third place.
Okay, this question is going to decide. This question, I think,
second, third, and fourth.
Kuldeep, Anand, they are all so close together. Okay, so close together. Kavit is, is sitting comfortably up, I think. Okay, but this question of Dr. Vishal is going to decide which 3 candidates will go to the final round. Great.
This is the
decider
versus RCB. Yeah.
This is the beauty of the Kahoot quiz by DocTutorials. Wonderful. Yeah.
CT scan. What is the etiology of coma in this patient? It's fairly simple. You can see the CT scan of a 70-year-old woman who was admitted to the ICU, has history of fall and decreased alertness. And you can see the left pupil is enlarged, right Babinski is upgoing, weakness on the right side. 4 of you have already answered. 30 seconds to go. It's a fairly simple CT scan. What do you think? Okay, 5 of you have already answered. So, yes. 20 seconds to go. Yes, it's chronic SDH with uncal herniation. It is not EDH. It was SDH with uncal herniation. You can see.
Can we go to the next one? I mean, the scores now.
Yeah, this is the final scores. We can see the final scores now. So third is Dr. Anand. Congratulations. You're moving to the next round. Dr. Kuldeep, very well done. Moving to the third round. And the first, I think we all know Dr. Kavit. He was way far up there. Well played, Dr. Mohit. And well played, Dr. Gopalakrishnan. Does not matter what happened. You already are a winner and you are going to get, I think, 3-month access for DocTutorials already. So you have already won. So congratulations. And next 3 participants are moving.
I should say that was a tight competition. I could see that.
Yeah, tight competition.
It is just a matter of luck, I know, but that was some fun. That was some fun.
There was an IPL happening here also.
Great questions also. I think all the questions of round 2 by Dr. Manish, wonderful questions.
Thank you. Thank you.
And I think, even for those candidates who have narrowly missed out, Gopalakrishnan, you also performed well. I think
Dr. Mohit
has missed out. Mohit, you were there, but again, just a bit unlucky. But Mohit, tell me, how was the experience with the quiz?
It was nice. Questions were very good, especially in round 2.
I think you did exceptionally well. You did exceptionally well.
Yeah.
It's a matter of luck. Okay. So, yeah, that's hearty congratulations, Mohit. Ravi, what will Mohit get? And also Gopalakrishnan and Mohit and Gopalakrishnan will be eliminated this round, correct?
Correct, sir.
But I think they were performing very nicely. Hearty congratulations, first of all, for clearing the MCQ round, then coming to the round 1 as well. Then round 2 also, you had a wonderful participation. So, Ravi, I think, they deserve a special applause for their participation. Okay. So, I think round 2 was very spicy, right? We had this, especially the second half. Just like in movies,
a lot of shuffling was happening.
Okay. So before, so thank you, Mohit, and also Gopalakrishnan. What was your experience, Gopalakrishnan, with the quiz? You had also answered very well because it's definitely going to be a tight competition. Gopalakrishnan, how was your experience with the quiz?
Thanks, sir. Thanks.
Hope your
The
experience.
top 5 in the country.
Yes.
Yes,
It's
sir.
great to be in the top 5 in the country. Okay. Hearty congratulations. Now, I think we'll go to the final round. Ravi, anything else you have to say?
That's it, sir. So after a couple of very, very exciting rounds, and mind-bending questions, as well as interesting clinical cases, we have our top 3 finalists with us. We have Dr. Kabir, Dr. Kuldeep, and Dr. Anand, who will be participating in round 3, which will be conducted by Dr. Rahul. And it is going to be best if Dr. Rahul explains the rules of the game for round 3, because it is all him in the 3rd round. And all the viewers over here, I'm sure you would want to be glued to your screens at this point, because this is a simulation of what is going to happen in your Viva as well, or what would have happened in your Viva. So this is a very, very intuitive round in that sense, and Dr. Rahul is going to take it forward from here. Dr. Mohit and Dr. Gopalakrishnan very well participated and very well played. You may not have made it to the 3rd round, but you still will have an access for 3 months for the DocTutorials courses. Please reach out to our help number, or in the group itself, you can contact me or you can contact Karthik from our team, so that we activate your courses for the next 3 months. Thank you so much for participating. Dr. Rahul, Dr. Kabir, Dr. Kuldeep, and Dr. Anand.
Congratulations, Mohit, and congratulations, Dr. Gopalakrishnan. Okay.
Thank you,
Yes,
sir.
congratulations to both of you, and good luck.
Thank you, sir.
Now, coming to the last 3. Okay. So coming to the final round. See, all 3 of you have performed very well in round 1 and round 2, because we have kept the quiz very structured. The round 1 was a warm-up type of round, and round 2, got the spice into the quiz. Now we have got round 3. So this will be a simulation of the, the Viva that you will have in your, residency rounds, or maybe exams. But again, not a detailed one, because this is, there is always a limitation of time. But please remember just one thing. I'll be giving you certain scenarios, and these scenarios will be neurology based, because I want to be uniform for these 3 candidates. And what I'll be testing you is not just based on what you answer, it's also based on how you answer it and how you approach. And that approach actually carries weightage. And do not worry if you get a couple of things wrong there, because if you can surprise me by even one answer that is really going to impress me on your approach, you will definitely get your scores high. And again, as you know, that even for your, the Viva exams in your college, the marks that are given the pattern might vary based on the examiners. So this will be my judgment. And I'm sure that, somebody else might see that, okay, this candidate answered better. And that is likely to happen because all 3 are almost equally good. So I'm under pressure right now. But again, I'll try to remain as unbiased as I can. And I'll try to make a judgment based on the performance. And again, I know that there is going to be an element of luck factor, because, if you get something that you are so solid about, again, you are at advantage. But that's how that, even for your actual Viva at college also, it goes like that, right? So let us actually start with the round 3, where it'll be a short round where I'll be just asking questions for a period of 5 minutes. Okay, just 5 minutes per candidate. And that's how the INI, because we have got courses for the INI, and the DocTutorials team, we conduct training not just for the INI round 1, but also for the round 2. So round 2 of INI is also a similar type of round, where you will have such sort of Viva questions, and you are given a time frame of 5 minutes. I might take a few extra minutes, 5 to 10. Let's take in that range, and we'll try to, find out who's the winner. So I think we have got 3 candidates. And I think, Ravi, in what order should I go for? You can decide, because I want to be as unbiased. So it's on you. You have to tell me who has to take the first go.
Sir, I think we have one current resident and two people who have already cleared their residency in the lot.
Okay.
So I would give Vaibhav Suryavanshi the first chance.
Okay. Okay. Younger gun. Okay, younger gun. So who's there? So is Kuldeep the one who's doing residency?
No, it is Dr. Anand. Dr. Anand who is in the second year of this.
Anand, right. Anand, so I think here is a question for you. See, the question for you will be displayed on your screen. Okay, Anand, just see this image that you're seeing on screen. And to begin with, I'm not going to give you any history. Are you able to see it, Anand? Yes or no?
Yes.
Anand, the first thing, I'm not giving you any history. I know that for any image, it has to be correlated with history. But I just want to see your radiological approach. Okay. I am just showing you this CT scan, and I'm just asking you to describe, not just the diagnosis. If you are in ward rounds, I am showing you the CT. You can describe. So that's, yeah, yes, please.
Sir, this is a non-contrast CT image of the brain, CT brain. It's showing an intracerebral bleed with most probably in the putamenal region. Most probably the patient can be a hypertensive. It could be a hypertensive bleed with no midline shift, and the patient is he's having some perilesional edema as well. And sir, should I say how should I clinically approach this case also?
As of now, you can describe the radiology. That's it.
Yeah.
Okay. Anything else you
there is no soft tissue abnormalities in the exterior to the skull, and apart from it, no herniation or midline shift was in evidence.
So it is always important to describe first in a proper manner. And you started off well, very good. You said this is
also
not.
It is a hyperdense lesion. Also, it is a hyperdense lesion in the putamenal region. Most probably, the patient will be an elderly hypertensive male.
So basically, you started off well, non-contrast CT, but I think you did not mention what sort of section is this.
Section.
This is an. You have to make a mention. So this is non-contrast CT axial section. And then instead of saying that this is a bleed, you will have to say, you corrected yourself in the later part, but you will have to say that this is a hyperdense lesion. And can you tell me where is the hyperdense lesion? Is it left side, right side, where?
It's in the left side, sir.
Left side. And you have to say, is it a well-defined or ill-defined one?
It's a well-defined hyperdense lesion, sir.
So you're having a well-defined hyperdense lesion. Where is the location of the lesion?
In the putamenal region, sir.
Okay, so you can see it is in the capsuloganglionic region, which is involving the putamen. And what about any features of mass effect or midline shift you are seeing? Any mass effect or midline shift you are seeing?
Sir, the patient, there is some perilesional edema, sir, with the minimal mass.
Very good.
Minimal mass effect.
Minimal mass.
Minimal.
Okay. No significant mass effect, but there is a minimal mass effect. Some sort of hypodensity that is surrounding the hyperdense lesion, which is obviously due to the edema as well. Okay, but otherwise you are not having any sort of significant midline shift. And then only you should say that this is likely to be an intracerebral hemorrhage in the left basal ganglia region. Okay, that's how you have to approach. Should not actually say, okay, straight away bleed, but I really appreciate you've answered some points very, very well. Okay, now just carrying forward with this question, Anand, I've got one scenario for you. Okay, I don't want you to be judged based on an image as well. I've got a very simple scenario for you. See, there is a patient. Anand, there is a patient who has been brought to the emergency department with an acute onset weakness of one side of the body, that is left side. And now the time, as you can see, is 8:20. And, as the quiz unfolds, so just imagine that the patient's symptoms started at 6 o'clock. And the patient is now in the emergency department at 8:20 p.m. And you are here as a medicine resident to attend that patient. Can you tell me the sequence of events that you will be, doing in the subsequent attending of that patient? Yes, please.
After the receival of the patient at the emergency, we can look over for the general conditions. We can look over for the airway breathing circulation of the patient, whether he is vitally, whether he is stable, whether he is breathing equally. We can also look at the GCS score of the patient. Then we can look at the vitals. If he is having some we should control the BP in initial stages of bleed, as well as if it is greater than 200 and all, 220 and all, we need to control the BP as well. So we can control the BP in the initial stage. If it is very high, then we can look all the ECG and everything in the ER itself. Then we can plan.
What do you mean by everything? ECG and everything? What else should be done? Should you take an ECG and then what?
ECG, then we can look at this. We can take an emergency CT for the patient. CT image.
The mimickers.
So, let me just ask you, as of now, you have seen the patient, you have assessed the general condition, airway, breathing, circulation. Okay, you have assessed the vitals. Okay. And then you said you're going to shift the patient to imaging. My question is, before shifting the patient to imaging, what are the tests that you will be doing? Or if at all, you'll be doing the blood.
We can look at the RBS values, blood sugar values.
Good, excellent.
We can rule out other stroke mimickers as well.
Clinically, it is important to rule out stroke mimics, correct? As Manish also said. And also two important investigation. One of them you mentioned ECG, and the second one, as you mentioned correctly, it is the GRBS. Right. Now the patient is now in the imaging gantry. Take us forward from there.
In the imaging, we can the initial part of the imaging is to rule out whether the patient is having bleed or not. If initially, we are not getting in the early stages of stroke, we may not get a infarct pattern on the CT scan. So we can take forward the patient for if clinically indicated, we can take forward the patient for a diffusion weighted imaging. And if on imaging, we can look whether the patient has involvement of any large vessel involvement or small vessel involvement.
I'm just asking a question. You said about the imaging. So you said that in the initial hours, sometimes CT may not show an infarct. So now the time is 8:20 and you have taken a CT scan. Suppose the CT scan is normal. What are you going to do?
Sir, if the CT scan is normal, then we can have two if we can take forward the patient, we can do an emergency neurology consultation, as well as we can take the patient for an MRI, diffusion weighted MRI, to look for whether localize the infarct and all. If the infarct is small infarct, then if it is like in the large vessels like ICA, like in proximal MCA and all.
So first of all, you should not be sending for neurology consultation. You should be managing yourself. Okay, don't call us. Okay. So, but I'm just telling because this is here to answer the approach. So it should not be asking me. Okay, because I'm the only neurologist here, so you cannot ask me for a consultation. But the point here is, see, my question is the CT is normal. Now, what are you going to do? Are you going to go for a diffusion weighted imaging, or are you going to start the treatment? That's what I want to know, because you said
we can start the treatment. We can start the treatment, sir.
You want to go for the diffusion weighted imaging because the CT is normal?
We can categorize the type of stroke regarding the need for thrombectomy as well.
So do you think, it will be wise to go for a diffusion weighted imaging? Then decide on the treatment?
Initially, we can thrombolyze patient, then.
Why not, because you have not seen an infarct, no? So don't you think you should go for the diffusion weighted imaging to see the infarct? No.
as a patient is having like 2 hours past the like 2 hours still there, we can consider diffusion weighted imaging for categorizing the stroke. And
you have to give me one answer. Are you going for diffusion weighted imaging? Are you going for treatment?
like if the patient already we have 2.5 hours left, so we can go for the diffusion weighted imaging.
Okay.
And
you still have more time. See, that's not how stroke has to be managed, right? Every second counts. Every second counts.
Time
And
is neuron.
yeah, every second counts. And if you have got, say, if you feel clinically it's a stroke and CT is normal, if it walks like a duck, quacks like a duck, it is a duck. It is going to be a stroke. So there is no point again doing a diffusion weighted imaging because, you know, there is no purpose enjoying the beauty of the infarct and then, you know, going for the treatment. You have to thrombolize the patient there. That's very important. Okay, that's very important. And
calculate the NIHS score and
exactly.
based upon that,
look at the NIHS score.
Rule out any
contraindications. Because, you know, if you have got the NIHS, which is sufficiently there so that there is some deficit, if it is 1 or 2, maybe, yes, you may not consider thrombolysis, but otherwise you will have to consider. And one point I have another doubt. So this point, you know, I think I have a difference of opinion. You will have to treat the patient there. And in the beginning, you were saying about BP control. So if the BP is high, so my question is, how high is this high for high blood pressure?
Sir, like we should, before thrombolysis and after thrombolysis, before thrombolysis, we should keep the BP should be below 220/110, and after thrombolysis 215/105.
No, you want to just take one more chance? Okay, I'll make it relatively easier for you. You know, the thing is, in this case, if we are planning for thrombolysis, what is the cutoff above which I should treat the patient? Number one. Number two, if I am not thrombolizing the patient, assuming that, you know, the patient came out of the window period, what is that cutoff above which I should reduce the blood pressure?
Sir, 180/110 is the cutoff for thrombolizing, and 220/110 is the cutoff which we should reduce.
For thrombolysis, 185/110, and for the patient in whom you're not planning thrombolysis, 220/120. That is the current guideline. Above that, you should be treated, right? So let me just ask you one thing. You know, you have done imaging. How important is vessel imaging in an acute stroke, and will it, by any chance, you know, influence the treatment decisions?
Sir, in acute stroke, we can thrombolize, and if it's a major vessel like ICA or if proximal MC infarct, we can have an option for thrombectomy. So we can, like, initially we can thrombolize and then we can
tested this patient in question. You know, suppose it's now 8:30 right now. Okay, 6 o'clock, the patient, suppose there is a large vessel occlusion. Okay, there is a large vessel occlusion. There is a proximal MC occlusion. What are you going to do? Are you going to thrombolize the patient or go for endovascular thrombectomy, or are you going to heparinize? What are you going to do?
Initially, we'll thrombolize the patient itself, sir. Then only we'll take forward with the thrombectomy procedures.
Okay, you do not directly want to go for thrombectomy. You want to, okay. What if the patient came at, you're right, what you said is absolutely right, very good. You have to do a thrombolysis followed by a thrombectomy, because the current evidence is that, you know, even for a patient with large vessel occlusion, we know that thrombolysis is not that effective for large vessel occlusion in comparison with a small vessel occlusion, but still you have to thrombolize followed by mechanical thrombectomy. Very good. Now just tell me that if the patient...
Unless the NIHS is more than 24, 25.
Yes. And what if the patient came at 5 hours, you know, 5 hours, and it is a, suppose patient came at 5 hours and there is no evidence of large vessel occlusion. Patient came at 5 hours, no evidence of large vessel occlusion. And your facility does not have any perfusion imaging, nothing, you know, no perfusion imaging available at your setting. So what will you do?
straight, you can do the initial management CT, and if the CT is, then we can straight away go with
basically, will you in a patient at 5 hours, can you do thrombolysis?
No,
What is
sir.
the window period for thrombolysis?
4.5 hours.
4.5 hours. So suppose your facility is not there for any perfusion imaging, you cannot go for any thrombolysis beyond 4.5 hours, right? Okay. What about mechanical thrombectomy?
Mechanical thrombectomy, if indicated, we can do till 12 hours.
Till?
12 hours.
12 hours. What are the two major landmark trials for endovascular thrombectomy which really redefined the cutoff points for, mechanical thrombectomy? Two landmark trials.
Must.
Both start from D.
Trial and the diffuse 3 trial. Okay, Dawn trial. So basically, mechanical thrombectomy, it's usually till 6 hours. But again, if there is sufficient evidence of a salvageable tissue on perfusion imaging, you can consider up to 24 hours. Dr. Manish, any question you will like to ask Anand regarding this particular case?
No, sir, I think the scenario which you were talking about, I would probably like to know if Dr. Anand, what would he do? Like if let's say the patient has presented in out of window period, let's say in 5 hours or 5.5 hours, and your setup does not have a perfusion imaging or does not have, let's say, an MRI or like a CT perfusion imaging or any mechanical thrombectomy capabilities. What would be the best step for this patient?
Sir, we can calculate the NIHSS score, and the NIHSS score again, we like as there is no diffusion, no setup available. We can thrombolysis. We cannot do, sir. We can opt out on thrombolysis. We can consider single antiplatelet if the NIHSS score is very high, and if the NIHSS score is low, we can straight away go for dual antiplatelets.
I think we tend to forget that the best thing for patient is also referral based. So I mean, it depends if you can send the patient to a facility which can do mechanical thrombectomy would be the best for the patient.
And probably, after giving, this particular case, you can consider a big dose of antiplatelet as well, if once you're done with your imaging, right? Right. So, Anand, can we give routine anticoagulation for acute ischemic stroke? In this patient, can you anticoagulate? What is the role of anticoagulation in the setting of acute ischemic stroke?
Sir, considering the etiology of the stroke, we can.
You can answer. In this particular case, will you go for anticoagulation?
We can we can give dual antiplatelets, statins, and BP controllers as well, antihypertensives as well.
Anticoagulation advised in acute ischemic stroke? Yes or no? If no, why?
No.
Or substantiate?
No.
Why not? Why not? Because in myocardial infarction, you are giving anticoagulation, no? Why are you not giving anticoagulation routinely in acute ischemic stroke? Because we know that in case of myocardial infarction, if it is ST elevation MI, non-ST elevation MI, you can go for anticoagulation. Why are you not doing the same in case of an acute ischemic stroke and restricting to just cardioembolic stroke? Why not in all stroke anticoagulate?
In ischemic, the risk of bleeding.
Okay. Why is the risk of bleeding more in the brain compared to the heart? Do you remember what type of necrosis occurs in heart?
Coagulative necrosis.
What type of necrosis occurs in the brain?
Necrosis.
Which one?
Liquefactive necrosis.
Which is more likely to induce a bleed, coagulative or liquefactive?
Liquefactive.
That's why, you do not routinely anticoagulate patients with acute ischemic stroke because the chance of bleeding is more. Okay. And with regards to drug approvals, any recent advances have happened in the last couple of months? Any thrombolytic agent being FDA approved? It was being used, but any formal FDA approval for any drug recently? Tenecteplase was tenecteplase. We have been using it, but just officially, the FDA approval has come recently. Okay, right. And just one last question. Have you heard about aspects? Aspects. You said about NIHS. What is aspects?
Alberta scoring system. According to the NC, in fact, the patterns, regions of the infarct, we can.
What is the total score?
Sir?
What is the total score? Alberta program score. And do you add or do you subtract? How is it done? The aspect score?
Sir, there are regions, certain regions are given certain.
Correct. That is right. I'm just asking how many points. How do you calculate? Okay. By the way, who is Alberta? Neurologist, neurosurgeon, obstetrician?
Neurosurgeons.
No, it's a place. It's a place in the Canada, southern province of Canada. Okay, not the name of a person. Okay, right. Anand, you have answered very well. Okay, considering that you are a resident, you are a second-year resident, Anand, or a final year resident?
Currently final years.
Very good, very good. You have performed very well. And Manish?
Yes, sir, very well.
Very good. So I'm sure that you would again refine your knowledge, and I hope you had a good experience with the quiz. We'll come back to you. Stay online itself, and we'll just quickly go to the other candidates as well. Ravi, yes, we have grilled Anand, who's our next.
So I was just thinking, sir, that I am very glad I didn't take up medicine.
The next person to be grilled.
Yeah, right. So I think next up we'll go with Dr. Kuldeep.
Okay, Kuldeep. Right. Right. And Kuldeep, and yes, Kuldeep, let's have your question on screen. Kuldeep, are you ready? Kuldeep, you're from which college? From which college?
AIIMS New Delhi.
AIIMS New Delhi. You've just done your MD, right? Right. So Kuldeep, right. So yes, Kuldeep, you just have got a scenario in your screen right now. This is regarding a 60-year-old male, known case of diabetes, also hypertension, presented with acute onset tinnitus and hearing loss in the left ear and vertigo since 8 a.m. in the morning today, followed by unsteadiness and swaying to the left side. On examination, left-sided cerebellar signs were positive, and I hope you have had a good look at the question, and I'm going to show you the imaging of this patient. Just tell me, describe the imaging first, and then tell me what is the likely diagnosis.
This is an MRI imaging of patient, and it is showing the hyperintensity in the left side of the cerebellum. And the section is axial section.
What sequence? T1, T2, player, what sequence? And is the hyperintensity only in the cerebellum? The predominant hyperintensity is located in which part?
The left side around near the midbrain.
It's always easy, when you just correlate with the history also.
So it is also involving.
So what sequence is this? T1, T2, flare, diffusion weighted, susceptibility weighted imaging, ADC. What is it? Or a contrast sequence? Okay, this is a diffusion weighted imaging, Dr.
Diffusion weighted image.
And tell me, where is the hyperintensity?
left part of.
Okay, so Kuldeep, this hyperintensity, if you look carefully, you can see that, Kuldeep, 1 second, let me just see if I'm able to, 1 second, just wait. Yes, Kuldeep, this is the pods, okay? This is the cerebellum. So what do you think this connection will be? It is the middle cerebellar peduncle, correct or not? Okay, middle cerebellar peduncle. And so there is a hyperintensity that is involving the middle cerebellar peduncle on the left side. Now, when you get a hyperintensity in diffusion weighted imaging with a corresponding hypointensity in ADC, what do you call it? Or in the setting of an acute ischemic stroke, suppose what is, your eyes, when you see a patient with acute ischemic stroke, you take an MRI, your eyes automatically go to the diffusion weighted sequences first. This is to look for what?
Diffusion.
Have you heard about
diffusion mismatch?
Not mismatch, diffusion restriction.
Restriction.
Can you tell me what is this diffusion restriction actually? Why such a restriction? Why such a restriction? What is being restricted?
In the MRI,
please.
Oh,
no problem. No problem. Be relaxed. I'll ask you. I'll give you a hint. There is a type of edema in stroke. Is it cytotoxic or vasogenic? You remember? Type of edema in stroke. Cell damage. So what will it be? Cytotoxic or vasogenic? Cell damage. So when there is cytotoxic edema, the cell size will increase. Okay. So between adjacent cells, there will not be any space for the water molecules to move. So there will be a diffusion restriction of these protons, right? So that is what is this diffusion restriction. Fine, no problem. So anyway, you have identified that there is a hyperintensity. I can see that there are small hyperintensities in the cerebellum as well, but predominantly. But can you tell me, how can we correlate this imaging finding with the symptom that you have got of the patient? Why the patient has got an acute onset tinnitus, hearing loss, and vertigo? Why? So I'll give you a clue. Okay. Have you heard about labyrinthine artery? Labyrinthine artery? Yes or no? Do you remember which blood vessel supplies labyrinthine artery? I mean, the labyrinthine artery is a branch of which blood vessel? It is the anterior inferior cerebellar artery. Okay. So when there is an anterior inferior cerebellar artery infarct, it can affect the labyrinthine vessel as well. And that is the reason why this patient has got these symptoms. And sometimes it is difficult to identify because this can be mistaken for an ENT problem. Patient might come to you in the emergency department with tinnitus, hearing loss. You might think this to be a ENT problem and refer it to the ENT doctor. But this is actually a vascular problem. And the onset of symptoms is going to give you a clue. The dramatic onset of symptoms. Okay, right. And the patient had some sort of unsteadiness as well. That is fine. No problem. Okay. Kuldeep, no problem. I'll just ask you some clinical questions as well. Okay. So this one probably you will be able to identify. Kuldeep, this patient had ataxia, right? So ataxia means there is some sort of incoordination. Kuldeep, can you tell me, when you hear this term ataxia, what are the possible sites of lesion? Where all can be the lesion in an ataxia?
It can be in the posterior tract. It can be because of the ataxia can be because of the hearing apparatus, because of the imbalance.
That is vestibular ataxia, one. Then
central ataxia, and because of that.
Wait. We'll just go one by one. Don't worry. First is vestibular ataxia. There can be vestibular ataxia. What is meant by cerebellar ataxia? There is a damage to either the cerebellum or the
vermis
peduncle. Cerebellar peduncle. Third, my question is, what is sensory ataxia? Sensory ataxia.
Because of the impairment of the proprioception, the patient is not.
Very good. There is a problem with the proprioception. Excellent answer. Can you tell me as you rightly said, the problem is with proprioception, but where exactly? Is it a problem in the nerve? Is it a problem in the dorsal root ganglion? Is it a problem in the posterior column? Where exactly is the problem? Or there can be multiple problems.
Posterior column.
Posterior column. So you're saying that posterior column involvement can produce a proprioceptive defect leading on to an ataxia. But let me ask you something. Patient with diabetes. I'm sure that in your routine practice, you have come across patients with diabetes. Can a patient with diabetic neuropathy have a sensory ataxia? Possible. How is that possible if you are saying that only the posterior column involvement can produce? So tell me, can the peripheral nerve involvement also produce sensory ataxia? Yes, it can also produce. And if it produces, in the peripheral nerve, you have got large fibers and small fibers. Can you tell me which fiber involvement produces a defect in the proprioception? Is it large fiber or small fiber?
The large fiber.
Very good. Excellent. It's a large fiber neuropathy that can produce a defect in the proprioception. So Kuldeep, you remember when you say sensory ataxia, it is not just about posterior column. It could be a problem right from the peripheral nerve involving the large fibers. It could be a problem in the dorsal root ganglion. It could be a problem in the posterior column. It could be a problem even involving the medial lemniscus. Okay, any of this can be, can actually produce ataxia, right? My next question is, when you talk about cerebellar ataxia, can you give me some causes of, ataxia in general? Some acute causes of ataxia. What are the possible etiologies? Acute causes.
Cerebellar bleed can cause the.
Okay, vascular, right? Then.
And the.
Bleed or infarct, vascular. Then.
And then.
Demyelination. It could be due to demyelination, right? And anything else?
And the hereditary.
Alcohol related, Wernicke's encephalopathy can produce. Okay, then infections, any infectious causes of cerebellitis can you think about? Varicella zoster can produce. Then
and
maybe drugs and toxins also, like lithium, phenytoin, mercury. Okay, so right. Now the next question I have to ask you is, how to differentiate between, have you heard about truncal ataxia? Because in patients with cerebellar ataxia, you can have truncal ataxia, limb ataxia. When you have got truncal ataxia, okay, truncal ataxia, what is a possible site of lesion? Truncal ataxia.
That vermis.
Vermis site of lesion. So generally, vermian lesions and flocculonodular lesions can have certain similarities, but what is the point of difference? How to differentiate flocculonodular lobe lesions from vermian lesions?
There will be truncal swaying
in
the vermis part, but
then what about dysarthria? Speech abnormalities occur due to vermian lesions or paravermian lesions or hemispheric lesions?
The paravermic lesions.
Paravermian, very good, very, very good. And what are the possible speech abnormalities in cerebellar lesions? Possible.
The scanning speech.
Very good. Scanning speech and
these it might cause, and it can also slurring.
Scanning speech, staccato speech. Okay, right. Okay, I think that's it. Kuldeep, you have answered decently well. Okay, and I hope you have to once again revisit the radiology part as well. Okay, basic radiology, we all have to be thorough as medicine residents, because, when it comes to actual practice, you cannot always rely upon the radiologist, because Dr. Manish is also, in the emergencies. So always he'll have to take decisions. So, but if you depend on another person, will always be a loss of time. So basic neuroimaging, we all should be aware about, than sending or maybe requesting for help. Yes, we might require guidance, but again, basic neuroradiology, we should be thorough about. Okay, good performance. Okay, Kuldeep. Right, thank you. Manish, anything to add?
Yeah, I mean, so when you started with the question, you showed the diffusion restriction on, am I right? If the patient presents to you in the emergency, let's say, with vertigo and tinnitus, and you are suspecting infarct, or you are suspecting like central versus peripheral vertigo, what is the test to go for? What would you do to differentiate between central and peripheral vertigo?
We can differentiate it between if there is any nystagmus is there, because the central nystagmus and the peripheral nystagmus, peripheral will die on and the central will stay, and there will be fatigue will be there. There will be direction will be the peripheral will be sent, the direction will be fixed, but the central one will be different, and also
There's a test. There's a name of the test. It involves nystagmus along with other testing as well.
yeah, that head shaking and that
Yeah. What is it called?
I'm not remembering that name right now. We have to shake the head and bring back the patient.
Yeah. Head impulse.
Head impulse. Yes, sir.
Yeah. What else?
And these the nystagmus.
You said nystagmus. You said head impulse. Then there is one more thing. Actually, two more things. Test of skew. And you do, this is called Hintz test, or then Hintz plus is there, where you also check the hearing bilaterally. So this can help you in scenarios where you're confused about whether it's a central cause or a peripheral cause, and it has a very high sensitivity in catching, central causes.
Right. Right. Thank you so much, Kuldeep, and let's move to Dr. Kavit. Okay. Right. Kavit, you're muted.
Yes, sir.
Kavit, I think we'll probably continue from where, we left off that discussion with Kuldeep. So my first question to you is, what is basically a central vertigo and what is a peripheral vertigo? Can you tell me what is a central vertigo? What is a peripheral vertigo? Yeah, that's my question.
Sir, vertigo that is arising because of lesions in the central nervous system, that is either the cerebellum or the vestibular nucleus. Those will be because of,
as you rightly said, the vestibular nucleus or its connections getting involved is definitely the center. What about peripheral?
Sir, peripheral will be because of peripheral causes, as in the eighth nerve or
the vestibular nerve.
Vestibular nerve, or the sensory ataxias will also be considered as peripheral ataxias.
Now, in your routine practice, how do you differentiate between central causes of vertigo? Like, if you want to differentiate between central vertigo and peripheral vertigo, not the nystagmus one, but central vertigo and peripheral vertigo, what will actually help you differentiate between these two?
So, starting with the clinical history, a patient with peripheral vertigo, the most common cause is labyrinthitis or vestibulitis. So, those patients will have a history of viral fever, or they will have some history of tinnitus or hearing loss. While patients with central vertigo, they will have more of stroke-like symptoms if there is involvement.
Point number one, as you rightly said, ear symptoms more favors the peripheral one. Right. Next point.
In the history for central vertigo, I will get, if there is cerebellum involvement, I may also get some brainstem involvement.
Right.
So in the brainstem, I might have associated hemiparesis in the history. Coming to the examination.
Any sort of brainstem signs, if it is there, it is likely to be central cause. Second point is also right. Third
central
point.
Cause.
Third point.
Yes. And then, yes. Then, sir, I will come to the examination. In examination, sir, there is the Hintz exam. Timing. Huh? Yes, sir. A peripheral cause will have a subacute history, which will be over days to weeks, while a acute central ataxia will have acute history, that is from minutes to hours.
Even a peripheral also can have an acute presentation. But anything you have to comment about the severity of vertigo? Who is more likely to have a more severe vertigo, the central or the peripheral?
Sir, central vertigo will be more severe, and it will not be responsive to certain drugs which are antihistaminics or anticholinergics. They don't tend to respond as drastically like peripheral vertigos to them.
That's not right. It is usually the peripheral vertigo, which has more dramatic symptoms. More vertigo will be in the peripheral compared to that of central. But when you have ataxia along with this, you will have vertigo along with ataxia that would actually prefer the central cause. But in terms of severity, what you said is not right. It is the peripheral vertigo that is more severe. Anything else?
So then coming to the systemic examination.
So nystagmus can help differentiate between central and peripheral cause. Can you just tell me, the differences between the central nystagmus and the peripheral nystagmus?
Yes, sir. Peripheral nystagmus will be unidirectional. It will point to the side of a lesion, while central nystagmus will be bidirectional. It will not have any particular direction. Second, nystagmus of peripheral vertigo will slow down and eventually fade away, while central nystagmus will persist. And then, sir, then we also have certain types of nystagmus which are localizing to the central system, like there's Brunn's nystagmus. Then we will also have skew deviation that we can do by cover and curve test. Then there is also Hind's examination.
Oh, that's okay. The head impulse types of nystagmus. You can just tell the differentiating point. You said about the type of nystagmus. One is unidirectional. The point is correct. And which is the one that is suppressed with ocular fixation?
Sir, peripheral nystagmus will be suppressed with using a Fresnel glass.
What about the latency? Latency of nystagmus will be there in peripheral or central? Peripheral nystagmus compared to central nystagmus. Okay. What about the fatigability?
Sir, peripheral nystagmus will have fatigability, while central nystagmus will not have fatigability.
Okay, all right. Have you heard about Alexander's
fast and slow component?
Have you heard about Alexander's law by any chance?
Yes, sir. Sir, I am not able to recollect it completely, but it suggests innervation, innervation of the same muscles that will lead to eye movement.
Okay. See, suppose there is a patient who is presenting to you with an acute onset vertigo, which is non-positional. Okay. So maybe for the last 6-7 hours, the patient is having an acute onset non-positional vertigo. What are the differential diagnoses that you will consider?
Sir, considering the most emergency diagnosis first, I would like to rule out a stroke or a hemorrhage. Then, sir, secondary could be demyelinating lesions.
What you said, vascular etiology is one probability. Involving which vessel?
Sir, involving the either anterior inferior cerebellar artery, posterior inferior cerebellar artery, or the superior.
Fantastic. And how to differentiate? Is it anterior inferior cerebellar or posterior inferior cerebellar? How to differentiate?
Sir, anterior inferior cerebellar will be giving branch to the labyrinthine artery. So I might have associated hearing loss, while the posterior inferior cerebellar artery will have lateral medullary syndrome of Wellenberg.
What else? That is one differential diagnosis. Your points are also well taken. What else?
Sir, another will be demyelinating causes like multiple sclerosis. Then, sir, there would be also infective.
Common for a multiple sclerosis to present with very rare. What else?
Sir, there will be traumatic causes. Traumatic causes like
common causes, other peripheral causes. What are central causes? You have said. What are the peripheral causes that you will consider for an acute non-positional vertigo?
Sir, there will be vestibulitis, labyrinthitis, some
acute non-positional. So it is a short-lasting one. Why don't you consider Meniere's disease?
Yes, sir.
You will
Meniere's
consider
disease can be
about vestibular migraine.
Yes, sir. That can also be a possibility.
Now, just imagine, contrary to this scenario, it's a prolonged vertigo which is lasting more than 24 hours. Non-positional vertigo, which is prolonged, lasting more than 24 hours. Now, what are your differential diagnoses?
So there I would like to consider chronic conditions like there could be a malignancy, CP angle tumor that could be compressing the...
Chronic, matlab not years. It is lasting more than 24 hours. Maybe the patient has got some symptom for like last 2 days or so, like that.
Sir, alcohol intoxication.
Would you still consider as one cause? Could be
yes, sir, vascular. Yes, definitely, sir.
It could be a stroke. What else? What else?
Sir, infections involving the cerebellum, vis-a-vis listeria rhombencephalitis can also involve the cerebellum. Then, sir, I will consider demyelinating causes.
What other peripheral causes will you consider?
related sensory neural hearing loss along with
labyrinthitis,
labyrinthitis,
vestibular neuritis. Okay,
vestibular
you have to
neuritis.
consider labyrinthitis, vestibular neuritis. Again, depending, the
Certain
patient
middle ear.
So it's a patient is having deafness, you will be having this labyrinthitis as a top differential diagnosis. If there is no associated deafness, you will have to consider vestibular neuritis as well. Okay. Now you will have
also certain middle ear pathologies like otitis media or cholesteatoma that is invading.
So you will have now one imaging on screen. So first, I'm not going to give you any history. All I expect is a description. Okay, no history, nothing. I have just given 6 images, 3 on top 3 sets is one sequence, and below that is a different sequence. Even if you don't tell me the exact diagnosis, perfect, but I just want to see your approach. That's it. Okay, suddenly you're having this image in front of you. I just want to see how you're approaching it. That's it.
So this is the axial section showing an MRI. The above 3 images are a flare image because the white matter is gray and the gray matter is white, right? And the CSF is black. So I assume I'm thinking that it is a flare image, while the below ones are the axial section of an MRI that is showing T1 image, where the white matter is white and the gray matter is gray and CSF is black. So, sir, the above are the flare images, the below are the T1 images. Flare images are more important to see demyelination, edema.
So it is just T1 or it's just any T1 or any addition?
Sir, it is a T1 with contrast. It is T1 with contrast. I'm able to appreciate.
Correct. Now you can describe the lesion.
Sir, the lesions are, sir, multiple lesions are there which are appearing concentric coin-like in some of the films. Along with that, sir, they are having a periventricular distribution, and they are widely distributed in the frontal region, in the temporal region, also in the parieto-occipital region. Multiple lesions are there, and they are also having some perilesional edema without any obvious significant midline shift, sir. I am not able to observe at the moment. Sir, most likely differential diagnosis.
What about you? You did not describe the contrast sequence. You said about the top 3. What about the contrast? What is the additional information that you got from the bottom 3 images? Additional information.
Sir, the lesions are showing contrast enhancement.
All the lesions?
Sir, if I come, assuming that both of those are of the same level, so considering those, if I'm supposed to get a similar image in the T1, so if I'm not able to observe a mirror flare and T1 sequence, so I will say that some of them are enhancing to the contrast while some of them are not. So suggesting dissemination in time, maybe.
So see, what etiology? You need not tell me the exact etiology, but again, considering this radiological pattern, again, I'm not giving you any history right now. But in routine practice, I know it's always, but I just want to see how a resident, like even without the help of a radiologist, are you able to come to reasonable conclusions? Just tell me, what are you suspecting? Is it vascular, demyelinating, neoplastic? What are you considering right now?
Sir, I am considering demyelinating as my first etiology, seeing the distribution of the images and seeing that I also have some evidence of dissemination in time with some perilesional edema. So, sir, my top differential in this patient will be multiple sclerosis, considering the periventricular distribution. Also, it could be a ADEM, sir, acute disseminated encephalomyelitis.
Is it common for a multiple sclerosis lesion, number 1, to be this big? Because classic description of multiple sclerosis lesions are, can you tell me what is a classic description?
Sir, they are
small avoid. And do you think, in multiple sclerosis, number 1, you get commonly, you may rarely get, there are fulminant variants as well, but common MS lesions, are they this big? Yes or no?
Sir, they are not.
Number 2, is it common for a demyelinating disease like multiple sclerosis to produce this sort of edema that you are referring to?
Sir, I'm not exactly sure, sir, but I would like to say it won't.
Okay. What, considering slightly larger fluffy lesions, what other demyelinating disease will you consider, especially if the clinical scenario is that of a person who has presented with altered sensorium and seizures?
Sir, yes, sir. Altered sensorium and seizures go against multiple sclerosis. So I would definitely put ADEM, that is acute disseminated encephalomyelitis, in the differential, sir.
Very good. Acute disseminated encephalomyelitis. Very good. Right. And you're absolutely right. When you get such large, fluffy lesions which are disseminated, I think, you're better off saying ADEM rather than multiple sclerosis. But you said MS, but no, MS I don't think will have these large lesions, and also the sort of slight edema is unlikely with, multiple sclerosis. And can you tell me, ADEM, is it monophasic illness, or, it can have recurrence?
So literature typically defines it as monophasic illness, but it could be biphasic. We have definitions like monophasic. And sir, a query.
Yeah.
Sir, could this be some dangerous variants of multiple sclerosis, like the
I said already that common variants will not produce, but again, larger variants, tumefactive variants can very well produce such sort of an appearance. And one more query I've got is, you said ADEM can be biphasic. So if a patient has an ADEM-like presentation that recurs, what is the other disease you should suspect? It will behave like ADEM, it can recur.
Yes.
You should suspect one disease. What is it?
Sir, anti-MOG associated disease, myelin oligodendrocyte.
Absolutely. Very well answered. Very well answered. No further questions. Very well answered. Okay. Very well answered. It's MOG. Okay. Good. So that's it. I think I have had my evaluation as well. Ravi?
Yes, sir.
So I think it was a wonderful competition. And in the round 3, which I just took now, first of all, I appreciate all candidates. And I also understand that, going live with many people watching you, there will always be some anxiety, apprehension. Even in an exam hall with, just 10 people watching, you will have apprehensions. But obviously, you will have that sort of anxiety. But again, all of you performed decently well. I'm happy with your performance. But again, I would request you to, once again, revisit certain aspects which you itself might have understood. So I just want to go through the candidates. Just want to, because they should say how was their experience with the quiz. So I think we'll just go to Dr. Anand first. Manish, can we just have their opinion as well? Dr. Anand, how was your experience with the quiz? You're muted. You're
muted, Dr.
Sir, it was a nice experience, actually. Also, I was also a bit tense to the initial questions and all, but somehow it was a nice experience.
Okay. Kuldeep?
It was very nice experience, sir. Earlier, I was just conscious that okay, it will be live. So what would happen if I perform pathetic and all those things? But you took the quiz in such a way that I don't feel like okay, I'm being threatened, or I'm feeling like I'm having some like what I'm. These are very simple questions and I'm not able to answer them. But you are guiding throughout the quiz, and it was, you tried so best, so much that even after not answering so many questions, I didn't feel okay.
That actually happens. I'm very sure that you're a bright candidate. Maybe what happens is sometimes if there is one particular topic that you are weak at, and sometimes the examiner asks question from that, unfortunately, maybe another topic thrown at you, you would have answered the best. So that happens. That is why I said, you all of you are performing well. We just saw that in the leaderboard, how Anand, your scores, were actually tilting. So I think you're all good performance. And Kavit,
luck plays a big role, sir. Luck plays a big role in questions and everything. Even like I realized I have to revisit my demyelinating disorder. I haven't read in a long time, being like in critical care and everything. I was like, half of the time, even I wouldn't have been able to answer half of the questions. I mean, if I were a participant, like, I mean, so it happens. Like, it's okay.
Kavit, how was your experience with this?
Sir, I am really glad that I could be a part of this quiz. It was a one-of-a-kind experience. I have never been part of a quiz that was in this format, and I've been seeing your videos, sir, since my UG days. Sir. So it was really a privilege to interact with you. I've also seen many of, I am following Manish sir on Instagram. So all of his content is quite, it's amazing the way he presents. So I've been a student of both of yours, and yeah, I'm really inspired by both of you. It was great being here.
Thank you so much, Kavit, and nice to know that all of you have enjoyed the quiz as well. And Ravi, how do we announce the winners? So can I announce now?
Yes, sir. Please go ahead.
So I personally feel, based on what happened in the last round, and I felt, that Kavit Shastri was the best performer for the final round. And I was really...
In all 3 rounds, sir.
Without any doubt. I think, he was the best performer. And some of the
Congratulations.
answers me as well.
Thank you, sir. Thank you.
There are certain areas you can improve as well, but overall, you performed very well. And I think, you can even improve further. I'm very happy with the way that you have answered, in such a competition. So first will be to Dr. Kavit. And second will be, based on this, again, I would say is Dr. Anand. And third will be Dr. Kuldeep. But again, as I said, it's just based on these random questions that I've put. Another day, it would have been totally a different result. But based on the questions I asked for this round and what I felt, this is my order, Kavit, Anand, and then Kuldeep. But all of you are top performers, and was really impressed by the performance that you had in the MCQ round as well. So this is what I would judge. And Manish, what do you have to say?
Yes, sir. I mean, definitely, I think Dr. Kavit was leading the scoreboard from the beginning, I think. So he did wonderfully. I mean, I've realized, I mean, his demyelinating disorders, the Viva was excellent, I think. Yeah, I mean, better luck. I mean, sometimes it happens that somebody is not able to answer from a certain topic, and we tend to forget, right? We are human beings, we tend to forget. I mean, so, I mean, yeah, I mean, we all need to revise, and maybe next time around things will be different. So congratulations to all three. All three are winners. I don't think somebody is less than the other. I think all three are equal. So yeah, they did wonderfully.
All three of you.
Yeah.
And Ravi, do they win some prize, or you're actually giving them prize or not? Any cash prize to the quiz masters also?
Yes, sir.
Yeah, definitely.
Master, sir, you should give us party, sir. Yeah. So as announced even before, the prizes for the quiz are as follows. Dr. Kavit, for bagging the first prize, bags ₹1 lakh in cash, along with 3 months of app access for NEET SS or PG residency medical group, whichever he chooses to opt for. Second prize goes to Dr. Anand, and Dr. Anand wins ₹70,000 in cash, along with 3 months of app access. And the third prize goes to Dr. Kuldeep. Dr. Kuldeep wins ₹50,000 in cash, along with 3 months of app access. So no one loses here. Everyone over here is a winner.
Yeah.
It is difficult to differentiate. It is difficult to differentiate among winners from when God from God's own country finds it difficult. That is a reference to you, Dr. Rahul. So yeah.
So I think, extremely happy with the way all of you have participated. And I think it's something that we should do often. I think, Ravi, this sort of engaging activities, during residency is often, I don't know, you can call it a stress buster or so, but, it gives you a different type of adrenaline rush, than you are in the wards. So, we should...
Sir, I can do it weekly once without the prize money part.
Yeah, okay. The prize money is what is getting them good, or is seriously good money. Okay.
Motivation.
Yeah.
That is the motivation, I guess.
Right. So I think we have been able to roughly keep the time as well. I think the 2 hours duration was we had thought, and it's almost 2 hours, and we had a good quiz. And also thanks to all the participants, because I could see Dr. Hiroval Mandi, Sonu, many participants, very active. Chandra, Prateek, so well done. All of you have answered very well as well. So thank you everyone for joining. And I should say that this quiz is a collective effort by the DocTutorials team. As I said, We have this medicine residency program. We are very particular about the training of candidates to be quality clinicians. That is our attempt, the medicine residency program of DocTutorials. And three of us, myself, Dr. Manish and Dr. Vishal, we have put in good effort to bring this quiz for you. And also I should appreciate Ravi as well, because a good chunk of credit goes to him for beautifully organizing this so that it was a visual treat, not just for the participants, but also for the viewers as well. For the smooth conduct, everything, hats off to Ravi as well for, being a part of this. So that's it. Any closing comments, Ravi, or shall we wind up? So how do they approach you for the prize? So can you just let them know as well?
Our team will approach them, or you can approach us. There are two admins to the group. You are already a part of the group. You can either approach Karthik, DocTutorials, or Raviteja, DocTutorials, either of us for collecting the prize money, or we will also approach with you. And tomorrow we'll be releasing an winner poster creative with the three of you as well.
So thank you, Dr. Manish, for those wonderful questions.
Thank you, sir.
And
thank you for teaching me also.
Yeah, you have also taught me, because I've seen, your videos, and I've learned that some things can be taught in a shorter span of time. That's what I'm trying to be mastered, because, in a busy life, it's all about time. And so, I am a traditional...
Attention span is going down, sir.
Okay.
We have to come up with different ways to teach.
Engage students. Thank you, everyone. Anand, Kavit, Kuldeep, all the best for your future as well. And do let us know as well, once you go into more heights as well. We'll be happy to be a part of it as well. Thank you so much, everyone, for joining.
Congratulations. And thank you.
Congratulations. Stay tuned to the DocTutorials YouTube channel for more such exciting videos or quizzes. Just stay tuned. Thank you so much.